We still have people joining, but for the sake of all of you who have already entered and so that we don't lose any precious time, I suggest that we get started. My name is John Coughlin, Secretary General of the International Cerebral Palsy Society, and I'm really happy to welcome you this afternoon, this morning, this evening, wherever you are, to our webinar on the WHO Global Report on Health Equity for Persons with Cerebral Palsy and Other Disabilities. The usual house rules apply here. You should all be on mute to start with. Please only unmute yourself when it's your time to speak. You have the option of following the captions, closed captions. Please don't change the language on that, because I think if you change the language for yourself, you change it for everybody. So it's in English. We're going to be having the seminar today in English. And we will have definitely time for discussion, for questions and so forth. Feel free to make any comments or questions in the chat so that we can gather them together. But don't worry, you will have an opportunity to speak if you wish to later in the webinar. So with that, I would like to hand over to the chair of ICPS, Nonyelu Nweke from Nigeria, to open this webinar.
Hello, it's good afternoon from me, and I welcome you to this webinar on the disability and health equity for persons with cerebral palsy and other disabilities. Most of us with lived experience, we know that apart from a direct result of their conditions, people with cerebral palsy and other disabilities face a lot of health challenges, often due to lack of adequate training or resources in the healthcare systems. Sometimes these challenges emanate from discriminations, which sometimes are subtle or even overt. If you have a child with disability or you're a person with disability and you have said public hospitals, you will agree, you probably would have witnessed these discriminations from healthcare professionals. Health in the ability promotes disability health equity. The World Health Organization, WHO, in 2022 global report shone a light on the problems of disability health equity. They didn't stop at that. In 2024, they proposed solutions to their guide for action. So today we are looking at the importance of these disabilities through a panel of discussants with lived and professional experiences from different parts of the world. So I invite you to what promises to be an interesting and informative discussions. And then there'll be time for questions and answers. So at the end of the day, I hope we are all going to enjoy this webinar. Thank you and welcome again.
Thank you, Nonye. And now I would like to pass the floor to our speaker today, who is Melanie Greot, consultant working at the World Health Organization in the disability team. And she's going to present. We have two presentations from her. One looking at the report on health equity for persons with disabilities, and the other looking at the guide for action. And in between, we're going to have an opportunity to hear from our panelists, but I will introduce all of those later. Thank you, and over to you, Melanie.
Thank you, John, and thank you, Chair. Hi, everyone. It's very nice to join you, and thank you so much for the opportunity to share some of the work that we've been doing at the World Health Organization to promote health equity for persons with disabilities. I'm really looking forward to the discussion that we're going to have together. So as John said, I'm just going to give a very brief overview of some of the key highlights of a global report that we launched in 2022. So it's been just about over 2 years now. So we launched a global report on health equity for persons with disabilities. A few highlights from this report. First of all, we updated the prevalence of the number of persons with disabilities globally. So with our analysis, we identified that 1.3 billion people in the world have a significant disability. That represents about 1 in 6 people in the world. And I usually start the presentations with this number because it can surprise a lot of people who think that persons with disabilities are a very small group, but actually 1 in 6, it's a considerable group in the population. And if we don't think about 1 in 6 people, we cannot achieve health for all. So it's really a group that we need to be thinking about every time that we want to strengthen the health system and health services. Another big piece of information that we outline in the global report, and the chair has already kind of touched upon that, is the health outcomes that persons with disabilities have. And a lot of people face health inequities. So poorer health outcome compared to persons without disabilities. So we identified that a lot of persons with disabilities can have premature death. Some persons can die up to 20 years earlier than persons without disabilities. A lot of persons with disabilities also have poorer health outcomes. They can develop health conditions a lot more than persons without disabilities. Persons with disabilities can have more than double the risk of developing certain health conditions like, for example, diabetes, strokes, or depression. And then there's also a lot of evidence that we gather in this global report to highlight some of the limitations in functioning that persons with disabilities have, and that really shapes their health outcomes. Now, what's really, really, really important to highlight is that these health outcomes or health inequities that are mainly due to unfair conditions that affect persons with disabilities disproportionately. So it cannot, or very rarely, is due to the underlying health condition that the person has, but the barriers that they may face, or usually the things that lead to these health inequities. And that's where the solutions need to be. It needs to be around tackling those barriers that people with disabilities face when they try to access health services, for example. A big chunk of the global report, and I don't know if you've had a chance to look at it, it's quite a dense report. It's about 300 pages, and probably about 100 pages of that is around analyzing what are the contributing factors that lead to these health inequities. So having done this analysis, we could identify 4 different groups of contributing factors. And I'm going to go over them quite briefly, but I hope we can unpack that during our discussion. So we have the structural factors that can lead to health inequities. There are also the social determinants of health, risk factors of diseases, and factors directly related to the health system as well. So when we talk about structural factors, and our chair already pointed to issues of stigma and discrimination, that's a very pervasive factor that can lead to health inequities. So stigma and discrimination that we can find in all strata of society, in all different sectors, including the health sector, of course, but also in everything that everyone does and in all communities, is something that can lead to health inequities. But also we need to be thinking about the policies or the processes that regulate our communities, but also the health system. Some of those processes, for example, might not include persons with disabilities. Their voice might not be heard, and therefore they cannot be part of the decisions to strengthen, for example, the health system. And then there are issues of governance as well. So when we do have policies that promote disability inclusion in the health system, it's not always that those policies are being implemented. Perhaps they are not those accountability mechanisms that can really make sure that we're on track with respecting and promoting disability inclusion in the services. Then we have the social determinants of health, and these are very important, and they can really directly impact the health outcomes. Things like poverty, transportation issues, education opportunities, employment opportunities, they can all directly link to different health outcomes. Just to give you an example, for example, if there are issues with transportations, persons with cerebral palsies or people who may have any type of mobility difficulty may not be able to access easily some of the transportation, the public transportation. Then they might need to rely on private arrangements to reach a healthcare service, for example. That can be quite expensive. Not everyone could afford that, or perhaps that might delay people accessing some of the health services that they need, and then their health status can decrease because of that delay. So that's just one example. But yeah, as you can see, there are many factors that can really have a disproportionate impact where persons with disabilities are impacted in terms of their health outcomes. Then there are the risk factors, things like physical inactivity, the misuse of drug and alcohol, high body mass index, air pollution, and smoking. So we noticed in the evidence that we reviewed that a lot of persons with disabilities have a higher risk of having those risk factors of diseases. But what's really interesting as well, and something that we need to be reflecting on, is that a lot of those risk factors, they are targeted by public health interventions, things like campaign to stop smoking or to raise awareness of the risk of being physically inactive. However, a lot of those interventions are often non-inclusive, so they might not be thinking about adaptation so that they can reach persons with disabilities. For example, for physical inactivity, if some health service, for example, recommends some exercises, but those exercises might not be thinking about how to adjust that for wheelchair users, then it's not accessible for everyone, and not everyone can benefit from these interventions. So that's also something we need to be thinking about. And then we have the health system factors. So looking directly at systemic issues in the health sector, things like health and care workforce, leadership and governance, the health system informations, and the service delivery. All of those factors can also not be done or provided in a disability inclusive way. So there's also a systemic transformation that we need to be thinking about of the whole health system. And here, COVID-19 actually really brought up a lot of those issues to light. So we had a lot of evidence coming from this health emergency that really pointed out some of the limitations of the system and how it was very, very exclusive of persons with disabilities. So I only have 2 more slides, just to let you know that the report doesn't just highlight some of the scientific evidence, but we also took a lot of time to gather some of the personal stories of persons with disabilities, really learning from people who had that first-hand experience to shape our understanding of health equity and health inequities that persons with disabilities experience, and then to inform the solutions that we will talk about in the second part of that webinar. So we talked with Fong, and I'm not going to talk too much about it because I believe we're going to hear from her a bit later, but just to let you know that she raised some issues that she experienced with her daughter with cerebral palsy, that when her daughter was born, and she couldn't find a lot of information, and even the staff at the hospital were not very aware, and she faced a lot of negative attitudes around how she could raise her child, and so that really impacted her experience of healthcare. And yeah, that was quite a bit of a negative experience. But then she learned from that, and I'm sure she's going to tell us more about how she kind of bounced up from that and did something really good. Another very interesting story and relevant to us today is Philippe's experience. So Philippe is a man from France. He has cerebral palsy, and he told us about his experience accessing oral healthcare. And he said that many simple details, including the texture of the seats, the light, the noise of the dental drill, and even the typical smell of the dental clinic could easily trigger spasticity, anxiety, or other symptoms for a patient with CP. And he said that he had a lot of terrible experiences trying to access oral health care. And he noted as well that some of the biggest challenges that he experienced was around the attitudes and the skills of the healthcare staff. And he advocated for more training and more respectful relationships, where the healthcare workers really provide this person-centered care and really take the time to understand the patient's needs. So I'm going to stop this first presentation on his words, and I very much look forward to hearing from the other speakers now. Thank you.
Thank you very much, Melanie. Sorry, I was a little slow to unmute myself. Thank you very much indeed for your presentation. And, and indeed, we're going to hear a bit more from Fong-Ha in a minute. I'd like now to present our panel. I, of course, forgot to share my own slides at the beginning, so you didn't see people's names. I will just do that now. So our panel, we have three members of the panel. First of all, Rafael Bonfim from Brazil. He's the co-founder of the Nossa Casa Institute. That means our house. It's an institute that promotes knowledge and understanding about cerebral palsy. And Rafael himself has cerebral palsy. The second panelist will be Abir Masad from Lebanon. She's the head of research and development at Cerebral, an NGO in Lebanon that works with children with disabilities. And our third panelist will be Dr. Michael Nierman, who's the medical director of Gillette Children's Specialty Healthcare in St. Paul, Minnesota, in the United States, which is a hospital that, in fact, specializes in children with disabilities. First of all, I'm going to give the floor to Rafael. And I'm going to ask you first, as a person with cerebral palsy, can you share some of your own experiences of health inequity in your own home country of Brazil?
Hello, everyone. It's a great pleasure to be here with all of you, with the panelists. Thank you, John, for your invitation. And I was actually reading our chat here at the room, and I saw so many people from so different countries and regions of the world. That gives me such a powerful feeling that we are not, we're not alone in our challenges and struggles and thoughts and ideas and solutions. So I am very, very happy to be here and be able to share a bit of my experience as a person with cerebral palsy. I am almost 43 years old. I'm going to be 43 in August. So I like to look back and think about things that worked out pretty well and other things that made having cerebral palsy an extra challenge. Because if I'm going to talk about the challenges of having cerebral palsy, there's a lot of things that everybody can also relate to, but also imagine or even presume, and they will be right. Brazil has a lot of challenges when it comes to accessibility in bigger or smaller cities, capitals of state or really, really small country cities. We have not a great public transport service. We don't have many accessible buildings when it comes to public service, not just only health and health access. So it is really hard to get around. But there are ways for me to kind of get around these things. And I had parents who had cars who were able to drive me everywhere. So that was okay. I do drive a car, so I don't have much of that problem anymore. And Brazil has a very good and solid system of public health that is free. If I were to translate it freely, it would be the universal health system. But in Portuguese, it's SUS. So people in Brazil can have access to health services for free, and it's not perfect. It has a lot of challenges and difficulties, but it works. But the thing is that once I do have access to, let's say, a rehabilitation environment, I have a different kind of challenge that is literally sitting across in my wheelchair from the person that is talking to me or that is going to think about my rehabilitation. The main challenge that I felt was trying to get across to that person as a real person. It's kind of funny to say this because that person, the one that is attending me, that is attending to my difficulties, that person might have knowledge when it comes to cerebral palsy or what it needs to be done when it comes to physical therapy, for example. But there is a challenge for that person to see me as a whole person, all of my needs, not only physical therapy, but especially why do I need physical therapy? What are my expectations when it comes to that? What do I want for my life? And how do I socialize? And how physical therapy, for example, might help me to be with my friends or to be in places that I want to go or to help me build my self confidence and build my self esteem. These are really, really important subjects that go way beyond having access or not having access to a physical therapy room, for example, or to a doctor for analyzing my cerebral palsy. We're talking about attitudes. We're talking about one of those pillars that Melanie brought up that was so interesting. We're talking about structure. We're talking about prejudice. We're talking about being discriminated for having cerebral palsy and not being perceived as a whole person, as a full person, as a person that wants to have job, as a person that wants to study, as a person that was a teenager and had a lot of issues in my head because I was a teenager, but also because I do have cerebral palsy and I needed someone to talk to about these specific issues. And just to wrap my experience, there is one other topic that is very interesting that is something connected to all of our health, and nobody talks about it. I need to say that I think that my main challenges came to me while I was growing up after my childhood, when I was a teenager and now as an adult. As an adult, I'm talking about job offers and the possibility of having a job and being paid well, and people looking at me and believing that I am a good professional, that I am competent, regardless of my cerebral palsy. And as a teenager, it was very, very important for me to be in touch with my sexual inclusion. This is something that we rarely talk about, and it's something very important. Nobody talks about it, but it's key. Every person with any kind of disability has the right to talk about this and to be informed about this and to have support when it comes to this subject. And it is a health challenge. It is something that has to do with health access. Having an active sexual life, healthy and secure, is something very important too. So I think that second subject wraps up two of my main challenges: working and having sex, maybe. Yeah.
Thank you, Rafael. So you've set a challenge for the future agenda. Thank you for that. But before going into those specific questions, I would like to turn to Abir and ask you, as a frontline professional working with children with disability in Lebanon, what do you see as the biggest challenges to health equity in your context?
Good evening, everyone. It's a large question, John, but I think the major challenge, my answer would be based on my background as a physical therapist working closely with children. So I think in Lebanon, the major challenge that we face is how we are able now to integrate tools based on the assistive technology to enhance communication and mobility with children in a low-income country. So this is the major challenge that we face. Now imagine like a child with cerebral palsy presenting a GMFCS level 4. For example, he may attend a mainstream school and complete his education in Europe or in another country, or even in Lebanon if his parents can afford this financially. However, it's not really realistic because of our inclusion programs problems. We have major problems. But imagine this child might be able to complete his learning program. However, the same child with the same profile will not be able to communicate his basic needs in Lebanon because he doesn't have the appropriate tools, for example, the communication tools. So now, like with the explosion and the progression of the assistive technology recently, and even I can't imagine in 10 years how things will change with our children. Imagine the gap that we will be facing, children living in a low income country compared to other children living in Europe or in the US, or even children living in the same country, but but if parents they have the means, so they can afford and they can provide them with the appropriate tools. For me, this is you are keen to find a strategy, at least within our institution at Cerebral, to follow all the guidelines and recommendation as much as we can, so we can improve our services. But at a national level, we have a major problem with this.
Thank you. You depict the situation in a country that has certain economic difficulties at the moment that we're all very aware of, and the additional challenges that that poses. But I think it's also interesting to ask, Micah, working in a high-income country, if there are also issues of health equity that you've experienced and you've observed.
Yeah, absolutely, John. Thanks. And I'll echo Rafael's appreciation for being a part of the panel and actually being able to talk with all of you and learn from your discussion. So for our experience, I think you'll find maybe it's unfortunate that the people with disabilities are still experiencing some of the same challenges, regardless of what country they live in. I think from my perspective, Melanie covered it quite well in talking about these 4 areas of inequity with structural, social determinants of health, the health system and risk factors. I think Habir and Rafael covered several really well. I'll focus a little bit on the health system, just given my focus, but certainly, I've seen it across all 4, absolutely, here in the United States. I think the biggest issue for people with disabilities is access. I think when we think about access, I think of it in different modalities. One is having funding. So for the United States, as you're all aware, we have both private as well as government payers. The patients or people with disabilities, in particular children with disabilities, they have far more support from a government payer, so Medicaid, Medicare, versus private payer. So when you're reliant on federal and state funding like this, it can sometimes mean that the way that care is funding is appropriated and the way that care is delivered across different states can be very different. I've actually been fortunate. The state where we are located is the state of Minnesota, which has a reputation of actually giving adequate funding and strong support for their Medicaid programs. But so that's one, just making sure that there's adequate funding, because oftentimes the funding is very different than if a patient has a commercial insurance, which reimburses far better. The other part of access also means location of services. So for people who are in communities that are low income, rural communities, access is becoming much more difficult to find. It's just given our financial healthcare model in the United States. And then if you do have access, there is a provider, if you have insurance, then finding a care team who's comfortable with disabilities, who's knowledgeable, I think that's the next obstacle. I mean, I have quite a few families who really, that's one of their biggest complaints is, and that's partly due to the fact that in some communities, that are relatively small, many of these providers just don't have the exposure and the experience. We could talk about that later, of how we address that. Other things just to keep in mind as well, if you think of durable medical equipment, you get feeding pumps or Foley catheters, wheelchairs. These are also incredibly important for kids with disabilities. What supplies are chosen, the funding for these is also very state dependent. So that can drive inequity. The other part too is this: when you deliver care, I think that's important to call out. And maybe it's something that I'm very attuned to just because of how Gillette delivers our care. But for kids with disabilities, they often have many different subspecialists. They have a lot more needs than the general population. So what you really need is good care coordination. That in and of itself requires good funding and knowledgeable teams. So it can be pretty difficult for health systems with tight margins, to build such a care coordination model that is both as comprehensive as possible, but efficient and sustainable. So those are just some of the things that I think about when I think of inequity, just when we talk about the health system, but absolutely inequities exist across the other areas. And I think Avira and Raphael spoke eloquently about those.
Thanks, Micah. Going back to you, Melanie, you really emphasized at the beginning the numbers in terms of the numbers of people with a disability, and about how you try to place that then within a framework which is very important at the moment of achieving universal health coverage. So if you are neglecting such a large section of the population, then it can't be called universal. What Micah identified there was also the fact that within disability, there's obviously a lot of diversity. And so specific disabilities, like cerebral palsy, that might be the most common form of childhood onset physical disability, but it's still relatively small numbers compared to the general population. And I was just wondering how do you put those arguments together? How do we see the place for people with cerebral palsy in a concept of universal health coverage?
Thank you. That's a really, really great question. And it's true that it's very important to acknowledge that when we talk about persons with disabilities, we talk about such a large and heterogeneous group. And it's very important to remember that, what is going to work for one person might not work for someone else. What someone might need might not be what someone else needs. And even, I'm sure, when we talk about persons with cerebral palsy, that does the same thing as well. We can't just say persons with cerebral palsy need this. There might be some common themes that are very dominant and prominent within this community. But when we look a bit deeper into personal experiences, and here I want to go back to Raphael's experience, he highlighted just two things that were very important for him, for his life, on how he wants to and correct me if I'm wrong, Raphael, but what's very important in terms of access to healthcare and how to live a healthy and happy life. That might not be the same for someone else with cerebral palsy. So I think so the strategy that we have to kind of reconcile these tensions of universal healthcare, but also person-centered care, is very much to, well, that's it. It's to really put at the center that we need to be looking at the person first and foremost. And when we do that, we do start to identify some strategies that are going to be helpful for a lot more people. Just to give you an example of that we keep using, because I think it's very telling and people kind of get it quite well, is the use of ramps, for example, in hospitals. A lot of people might think, oh, that's only for wheelchair users. It's such a small number of people. First of all, it's not such a small number of people. It really helps a lot. But it doesn't just help persons who are wheelchair users. It also helps people, for example, pregnant women. They might really struggle climbing up the stairs, but having the ramp actually is quite helpful. It can help people who have some mobility difficulties, like if your knee is a bit in pain, you might prefer to use the ramp rather than the staircase. So it's about highlighting that disability inclusive strategies are actually very beneficial, not just to the persons with disabilities, but to a much larger group that we cannot tend not to see. And that's what we want to focus on when we try to promote health equity for persons with disabilities and transforming health services to be more inclusive, because that really benefits a much larger group.
Thank you, Melanie. Now let's turn to the participants. If you have any comments or questions you would like to ask. I noticed there's one comment from Sonali Shah in the chat, pointing out that the major challenge in all countries, including the UK, where Sonali is based, are attitudes and ableism. I don't know, Sonali, do you want to speak to that? Let's see if you're on mute. Are there any other comments or questions from the participants? If not, then we can maybe move towards the second part of the program, because we really want to look not just at describing problems, but also looking for solutions. First of all, as was already mentioned, one of the members of ICPS is the Cerebral Palsy Family Association of Vietnam. And Phong Han Nguyen, who is the mother of a child with cerebral palsy and one of the founders of that association, was actually interviewed for the Global Report back in 2022. It's quite late at night in Vietnam at the moment, so we asked if she would do a short video message to share a kind of an update on her situation since then. So I would like to share that with you now.
Hello everyone. My name is Phương Hà and I am a mother, a mom of a daughter with cerebral palsy, so severe. And she has been my greatest inspiration. She is the reason that I found the Superhero Family Club, which later becomes CPAPV in Vietnam. And she also the reason I decided to return to university and pursue a career as a therapist in rehabilitation, learning live by my own, travel around the world to study, and eventually open a small center for children with cerebral palsy like her. Since my interview with WHO in 2023, many things have changed. I have stepped down from my position on the CPIPV board and focused on researching a new method, like new way for children with cerebral palsy. And now I have returned to CPIPV in a professional capacity, contributing as a specialist in the field. When I'm looking back on this journey, I sometimes wonder how I managed to do all of it. I remember the days when my daughter and I studied abroad together, holding each other while learning, making the most of every lunch break to feed her. The more I reflect on it, the more I realize that being a mother of a child with cerebral palsy has pushed me to be stronger than I ever thought possible. But no matter what role I take on, my heart will always belong to my daughter and to the community of children with cerebral palsy, both in Vietnam and around the world. And finally, I want to express my deepest gratitude to each and every one of you watching and listening to this video. Thank you for always understanding, loving, and standing by the cerebral palsy community. What you do truly makes the difference. It brings hope and real change, not only to the cerebral palsy people, but also to their parents, their grandparents, and the family member as a whole. Thank you and goodbye.
So that's a really sort of impressive statement from Phong Ha, telling a story which I think there will be other parents on this call who will know that experience of actually going away and getting yourself trained up professionally because you feel that there's this need to provide these services that are missing for your children and then for other children, and then to go on for that for further generations. And it's also important, as she reminds us, about it's not just about persons with disabilities, it's about the whole family around them. And that support structure is also important. So I think in your numbers, Melanie, you can even sort of go up many more multiples about how many people are affected by these issues. So with that, we'd like to turn to look forward to the guide to action and ask you, Melanie, again to present what you suggest and recommend for going forward.
Thank you, John. Can you see my screen again?
Yes.
Yeah, great. Thank you so much. And thank you for the panelists for sharing their perspectives. That was very insightful. And yeah, as you said, John, I think it's very important to recognize the challenges and to talk about that. But it's also a good thing to be thinking about the solutions, because there are many solutions that we can start to talk about and to try to implement some change to promote health equity for persons with disabilities. And that's where the second part of the webinar that's what it can do. So before going to the guide for action, I'm actually staying a little bit more on the global report. So the global report, I presented the sort of first half just before. And so we identify some of the contributing factors to health inequities. The second part is actually learning from those lessons and try to provide some recommendations and lead some actions to promote health equity for persons with disabilities. So the big approach that we try to recommend to member states and to different countries is not to develop a separate disability inclusion plan, which is often what we see happen in disability inclusion, is to develop this thing that is usually a siloed project alongside a system or a service. And that kind of sits on the side of what the system is. And usually it's well funded at the beginning, and there's lots of great recommendations. But what we identify is that there's usually some difficulties to integrate that within the system to actually have those actions being implemented, followed up, monitored, and leading to the actual change that we want to see. So what we recommend is actually to stay within the health system and the health services, and to identify within the existing system what can be done, what can be tweaked, which kind of actions can be added on top of what is already there to strengthen the health system through disability inclusive actions. So on this slide, you see the big framework that we recommend to promote health equity for persons with disabilities. It's quite comprehensive, and I'm not going to go into all the details. I just want to bring your attention to the middle column, the one where you can read strategic entry points. So what we're trying to do here through strengthening the health system is to look at how the health system is itself structured. And we see those different pillars, building blocks, or as we call them, strategic entry points that make up the health system. Anything from governance, which is one of those strategic entry points, to the financing of the health system, which is another very big consideration, all the way again to the healthcare workforce, which is another big consideration, physical infrastructures, all the buildings and facilities of the health system. So we look at all of them, and there are 10 of the strategic entry points that make up the health system. And we're going to do a deep dive into them and looking at what are the different actions that can be done within those 10 strategic entry points to promote disability inclusion in the health system. In the global report, we identified 40 different actions that can be considered to really advance health equity for persons with disabilities. And I'm not going to go through all of them. There are too many of them for this webinar, but you can see that they are all embedded within one of those strategic entry points. So some have more actions, others have fewer actions, but they are kind of guidance, kind of overarching actions that countries can start to think about to promote more disability inclusion. So that's for the global report. But as you can imagine, every country is quite different. They have their own context, and they're not starting from the same place when we think about disability inclusion. So what was very important, literally the day after the launch of the report, was to think about developing a toolkit that could guide ministries of health efforts towards promoting health equity for persons with disabilities, and really scaffolding this process, helping them to go on this journey to promote disability inclusion in the health system. So we published this guide for action very recently. Actually, it was published only in November 2024. So it's only been a few months. This disability guide for action really supports the ministries of health to advance health equity for persons with disabilities. And what it does is that all the 40 different actions that I just mentioned briefly just now, we know that no one can do all those 40 actions. It's not realistic. So we accompany ministries of health through this toolkit to strategize and to prioritize which entry points or the most strategic for the country, for the specific context, and to really set them on a journey to implement some processes and some mechanisms to make sure that those actions that have been identified as the most strategic to promote disability inclusion in that country are really followed through and really lead to the outcomes that we want at the end of the day. So the target audience, as I said, we're very much wanting the ministries of health to be leading on this process because it's their responsibility. They need to be in some ways held accountable, and they are the ones that can really promote the most systemic change that we need for this process. However, they are not alone. We really highlight through this toolkit the importance of having a consultative process and really engaging with a lot of the different health and disability actors, including organizations of persons with disabilities that have a big role to promote this work. So this toolkit, it's structured in 4 different phases. The first phase is prepare. So this is about raising awareness among the Ministry of Health, focal points, and all the different stakeholders, raising awareness about what do we mean when we talk about health equity for persons with disabilities. All the numbers that I told to you in the first presentation, we need to make sure that people are aware of that and really appreciate how important it is to move this agenda forward. And then we start to have a group of people that we call the working group that will follow through this agenda. Then there's a second phase, which is the assessment phase. So here it's very important. Basically, it's the phase where we look at the 10 different strategic entry points and we look at what's happening in the country. What are the challenges that people experience? What are the gaps in the health system? What are the stories of persons with disabilities in that country? What is important for them? So we do a lot of consultations, bilateral meetings with the key stakeholders, a lot of research, desk-based research background. So a lot of activities are done to have a report on the situation in the country on health equity for persons with disabilities. Based on this, the working group then moves on to the third phase, which is design. So when we have this very good overview of what's happening in the country, the working group gathers and is going to try to identify, okay, what are the strategic actions that we can try to promote in the country to make sure that we can have some change towards more disability inclusion in the health sector. And then the last phase, the fourth and last phase, is around implementation and monitoring. So making sure that we have a mechanism in place to be able to monitor that the actions are actually leading to change. So the Guide for Action, as I said, it's a toolkit, and we have lots of tools available, and they're all available for free on our website. So I'm going to put the link in the chat after I'm done talking. And just to give you an overview, so there's already quite a few different countries that have engaged in the process. We have, for still at the first phase stage, we have Indonesia, Tunisia, Egypt, Cambodia, and Solomon Islands. Then there's Nigeria that is currently in phase 2 of that process on the situation assessment. Then we have Montenegro, Nepal, Côte d'Ivoire, and Malaysia, which are quite further down the line and already in the design and action planning phase. And finally, Tanzania is the first country that has completed the whole process, and they are in the 4th phase of implementation and monitoring. On this slide, and I'm almost done, I promise, John. On this slide, I just wanted to show an illustration from Côte d'Ivoire. So Côte d'Ivoire, as I said, is one of those countries that has started this journey, and they're currently in the 3rd phase of trying to identify which actions are going to be taken. And what I put on the slides is different photos of phase 2. Where we did a lot of research and we had loads of meetings to discuss with the key stakeholders in the disability and the health sector really trying to understand the situation and what are the opportunities to promote health equity for persons with disabilities. So we did lots of consultations, and the second photo is from a consultation group with women with disabilities, where we listened to their stories and what was important to them and what they wanted to tell the ministries of health that needed to be changed. And that's it for me for an overview of both the global report and then the guide for action, which is that toolkit to really see through some changes on the ground. And yeah, you can reach out to us. We have a website, and I'm going to put the link in the chat where we gather all those resources. And I'm also I'm going to put in the chat my email so that you can reach out to me if you have any questions. But yeah, no. Over to you, John. Thank you so much.
That's great, Melanie. Thank you very much. And my question was going to be about whether any countries have signed up. So that was great to see that you're already actually working on the implementation of this with a number of member states. And we have some representatives of those countries here today as well. So it'll be interesting to know to what extent that's filtering down. I guess it's very early days, but I think there would be grateful to know that their governments are engaging with this.
Mm-hmm.
Now, to turn back to our panel before we come to a final round of questions and answers, I want to turn to Mike and ask you, as a hospital that specializes in dealing with children with a disability, how do you promote inclusive healthcare?
Yeah, I think the way we've done it, and this is what we've done Gillette was founded actually 128 years ago. And it was really an idea that was brought about by a young woman who could have been a patient of Gillette. And I think given how we started, I think that's defined how we've really modeled our care. And that is that the patients are our North Star. So we put patients and families first. They're an integral part of our care team. I think Feng's message about, being a strong advocate, for her child, I think is really illustrative of why our kids do so well. There's an extraordinary amount of dedication, time, love that families and caregivers provide. And so what Gillette does is we really try to tap into that and support them, and making sure that patients really do the best they can. And then what we do is we take our evidence-based practice and then we tailor that then on an individual approach. So really seeking the individual goals of each patient. I think, Melanie, you're talking about how you balance that universal coverage with people with CP. John, that was one of your questions. And I think that's what we try to do, is understanding that disability is very heterogeneous, but everybody will have different needs and different goals. And so how do we fit that within the context of what we do know is the sort of what is that best care? We also do this, we foster an environment of inclusivity. We look at our quality data. We look at, when we talk about access, we look at transportation, we look at people who speak English as a second language or their ethnicity, to see, are there differences in their ability to access our care, for example? And when there are gaps, how do we address those to make sure it's equitable? We look at where people are as well. Quite a few of our patients come from rural areas in the state. So we have, one of the silver linings in the pandemic is the development of a strong virtual care program. So we have relied heavily on that in order to minimize their transportation. We have satellite clinics throughout the state. The other thing that I think is really important to call out is we have a strong clinical research program. So what we have also done is brought in lived experience partners. We have a family engagement and research where when we ask questions about advancing our care, we want to make sure it's meaningful for our patients. So they are involved in that process and give us feedback. And I think a great example that was brought up at the beginning of the presentation was Philippe's dental experience. And I think we are doing research right now around pain with kids with cerebral palsy, and understanding that they experience pain far differently than the general population, which means we have to approach the management and the control of pain to be very different. And again, gets back to that individualized approach. So that's how Gillette has done it. Granted, we also understand it's a pretty unique perspective. I've been at other healthcare systems in the United States where they haven't had that type of sort of patient as the North Star approach. But it's a constant. Gillette does it well, but we still have gaps, and we still are learning how we can be better.
Thank you for that very comprehensive comment. You really sort of picked out some key themes, I think, which we really need to bring forward. Sort of underlying principles of the approach that needs to be taken, and perhaps what you're also hinting at is that this person-centered approach, it's actually about making healthcare better for everybody, recognizing individual needs. It's not a specific special attention for the disability community. Abir, if I can turn to you and ask, looking again at the situation that you find yourselves in Lebanon, looking at the Guide for Action, what do you think will be the main challenges in implementing this guide? And I know that Melanie emphasized that you don't expect to do everything all at once. You want to pick it up, but what do you think will be the main challenges to implementing it in your context?
In my context, we cannot ignore the challenges related to specialized and appropriate resources and funding. Also, another challenge we are facing in Lebanon is the implementation of strategies. I will give you an example. Like according to the Lebanese law enacted in 2000, persons with disabilities have the right to access healthcare, rehabilitation, and support services. However, they have never access to these services or to these specialized services. So if our government would like to take action and to incorporate these actions, we have problems with the implementation. I will give you an example. For example, after stating this law, the government has defined a comprehensive strategy related to this law. For example, as a practical example, and under the action points of models and quality of care defined by the WHO, a child with CP, he may be eligible for a sitting system in our context or a wheelchair. However, in most of the cases, if not all, the provided equipment is not appropriate and fails to meet the wheelchair provision recommended by the WHO. So we have the process, we have the strategy, and if this strategy is implemented, most of the time, the service is not appropriate. So we have, because of the funding and the appropriate resources. So when I was reading all these points, okay, I know we have major challenges and we have to take maybe baby steps. Okay, I think the private sector is doing a huge job. I can give you an experience at Cerebral. We incorporated the WHO recommendation related to the wheelchairs, and we even trained 90 professionals within the country in our center. But still, although they are trained, the strategy is never implemented. So we have major challenges because we don't have appropriate human resources and fundings. I believe that maybe adding the term appropriate whenever it comes to care or service, this will be maybe will help us to improve as much as we can services, because the government will refer the child for a center. However, this center for rehabilitation, they do not have like pediatric rehabilitation. They have like conventional physical therapy for adults. So the process is here, the strategy is here, but it's not appropriate. So because of the funds and the specialized human resources.
Thanks, Javier. I'm just looking at some of the comments in the chat. One of them, maybe I can ask Melanie if you can comment on this, which is, I think it reflects the fact that, as we were saying earlier, disability is diverse. So we saw in your example from Côte d'Ivoire how you were consulting with different disability groups. But you know, if you're from the cerebral palsy community and the groups who are consulted are people who are blind and deaf, then it's not going to be necessarily the same needs. We were talking about the diversity of needs and the specificity of needs. So could you say something a little bit about how you engage with these groups, how you identify which groups, how does it actually work in country to country basis?
Thank you. That's another really, really good question. I think so. We do work a lot during the implementation of the guide for action with organizations of persons with disabilities. So themselves, they usually organized at the national level. And they are the umbrella organizations that usually have then those more specific organizations. And we do keep an eye on whose voices are there, who sits at the table, and if there's too much representation of one group, we keep that in mind to make sure that other people with different needs might also be included. Usually the organizations of persons with disabilities are very good at doing that themselves. I think it's part of their role and their responsibilities. But yeah, we do keep an eye on this. It is very challenging because, of course, it's hard to have everyone with every health conditions. But actually, when we look at some of the actions that come out from the Guide for Action, they usually broad themselves. So, for example, we were talking just now about the importance of healthcare workforce attitudes and the need to promote disability inclusion and to change attitudes within the healthcare workforce. That's something that can be done with a disability inclusion lens in general. Then we have those more specific examples, and we need to give that diversity in the examples, but the principles are usually there and apply to a lot of people. So we try to take that sort of overarching approach and then make sure that we have that diversity as much represented as possible in the process. But if any of you is interested in actually following up on the Guide for Action, seeing how that can be implemented in your country, then we can look at that as well, and making sure that persons with cerebral palsies are part of that discussion.
Great, thank you for that. And I would emphasize also that, you know, we were part of the Civil Society Commission of the WHO, which was just set up in the last couple of years. And we see this as a problem across the board. It's not just something specific to the disability field or to our community. It's that for a long time, Dr. Tedros, the Director General, describes the WHO as being shy by design and not making a big effort to go out and to engage with civil society groups and so forth. But that's something that's changing a lot in terms of the culture of the organization. But it's still an ongoing process in terms of getting to know how to engage, and that has to filter through not just the headquarters in Geneva, which is where the global report is coming from, but through to the regional offices, the national offices, and so that's an ongoing process that we should all contribute to as actively as possible, but also not be surprised that it's not all perfect from the start. And I think it's really great that there is this openness and this willing to engage. Raphael, can I ask you now, as a you know, from the user perspective, when you look at that Guide for Action and those recommendations for member states, what would be your top priority in terms of achieving greater equity in health?
Well, Brazil is actually something else. I was thinking about this while listening to all of you and reading the comments and chat, and it's something very intriguing actually, because we do have a very, very good body of legislation here in Brazil. if anyone gets curious, the Brazilian inclusion law is a very interesting read, or in Portuguese, it's going to be LBI. It's very, very good. Brazil has laws that will protect children with disabilities and will grant them access to health and school and actually jobs. I do have legislations that touch these three very important pillars of development. But I have really good pieces of legislation on one hand. And in the other hand, I have really bad attitudes from public managers, politicians, and people. So I have really good pieces of legislation in one hand and really pieces of something not good on my other hand that just talks about our attitude and the way that we look at people with disability and people with cerebral palsy. So, regardless if we do have money or we don't have money, I think that for us, one of the main key factors is community empowerment. That is very, very, very important. And I would also like to add that looking at my history, I think that is very obvious that one of these things that were very, very good for me was the possibility of just being there. So if I could just address one attitude that I really think is essential, regardless if you have a lot of money or if you don't have any money in your pocket, is that just be there, just go, just be present wherever you can be present. If your countries have no accessibility, but you can be present at family gatherings or go to the park or whatever you can do, just do that, because that person that is there with you is going to grow up. That children is going to become an adolescent, and then it's going to become an adult. And these social interactions are so very important, not only for that person, but I really believe that that is the backbone of strengthening communities and strengthening the people with disability group, because we need to be there, we need to be present, and we need to communicate however we can. I don't care how that's going to happen. It's just important that it happens. So one, be there. Number two, talk about the future. No matter how difficult it is or whatever the topic is going to be, talking about a future is very important, because if I have somebody with cerebral palsy that was a child from 0 to 15 and was an adult from 20 to 70, that's a lot of years being an adult and dealing with the future. So it's important. And number three, make allies. This is a very, very important topic, because we're dealing with a very important challenge and a very difficult one. You are going nowhere if you don't have allies. And your allies can be anybody and anyone that you think that can help you address your challenges. It can be somebody from healthcare, it can be somebody from your family, it can be anyone. It could be a teacher, so on and so forth. So I think that for us, strengthening communities is very important, not just for us in Brazil, but for any other country. I think it's crucial, because somebody said it very well here in the chat, that their main challenge is ableism and attitude, and that is it. You can have a very, very good country with a lot of money and a lot of respect and a lot of infrastructure. If people inside those infrastructures are going to treat you badly, it means nothing. So yeah, just be there. Just go. Go to those places. No matter how tiring it is, you have to be there. You can't hide. Not anymore.
Thanks, Raphael. Those inspiring words. And are there any more questions or comments from participants? I know there's one comment in the chat about financial resources and the lack of those financial resources. Obviously, that's going to be a challenge everywhere and something we also need to do about. But I see a couple of hands up from Mathieu Châtelain was the first one.
Thank you very much to Melanie and all the panelists for your time and your inspiring presentations today. I just had a very quick question, but because I've got cerebral palsy myself, you can probably see it with my arms. The only question I had was, you talked about the fact that the lack of physical activity is an issue, but do we have resources or tools, for example, for people who have GMFCS 4 or 5, and never forget the 5, who rely on a carer on a daily basis? And in that case, if the carer is forbidden by law from basically doing an effort or assisting the person herself with a few steps or something like that, and that the only option is to use a hoist, for example, then it may have a big impact on our life expectancy at the end. So how could it be addressed? Thank you.
Thank you, Mathieu. I suggest we take a few comments in one round, then give the panel an opportunity to respond. Anna.
Yeah, I have two comments or question. I don't know. The first one, we're speaking about healthcare, but in fact, there are connections between life trajectory and health trajectory. What I mean is, yeah, you have goals for your life, and you have also for your health trajectory, you have goals regarding care and therapy, and it's difficult to consider those goals separate. For instance, if a child needs to, or don't need, is willing to go to school, then it may be useful that someone is able to explain what are the specific concerns, for instance, regarding cognitive questions, dyspraxia, dyscalculia, or so on. And it can be the same when you're looking for a job as an adult. There is a need for some adaptations. And I wonder how we can reconcile these life goals and healthcare goals, because in my opinion, they are connected. And more of a comment than a question is about the fact that yeah, a guide for action. You've presented the examples of various countries, and I feel ashamed to say that I would really consider your help for providing re-engineering in rich and old countries like mine in France, because we have so many layers of inefficient services that accumulate. We have so many inequalities regarding conditions and various regions in the country, that we would certainly need a re-engineering, maybe not from the start, but from the very beginning, to have a new look on our systems, even in rich countries. Any comment on this?
Let Michael come in here from Nigeria, and then we can turn to the panel for their reactions.
Okay, good afternoon. Thank you very much for the wonderful presentation. I was just wondering, most of the issues raised during the presentation are things we face, excuse me, things we face directly here in Nigeria. So are there opportunities out there that, since you're already in the field, we could partner with you in terms of implementation and in building the work frame, given that we do this work, we are on field, we are in the field, we know what's going on. Don't you think it's good for organizations like WHO to partner with our local organizations, and how do we get them implement these projects here in Nigeria? Thank you.
Thank you for that, Michael. So, Melanie, I think we'll give the floor first to you, and then we'll ask the other panelists if they have any extra comments.
Thank you. Yeah, I'm sorry for Michael. I couldn't hear, like it kept breaking. I think my connection is a little bit unstable. So if you don't mind, perhaps writing it in the chat, and I'll try and address a few other points before going back to you. I'll start with Alain. Because I'm from France as well, so I'm very aware that the system is not perfect. And the Guide for Action, it's true that we often think about disability inclusion or the work that WHO is doing for low and middle income countries, but that's really not the case. And especially on the topic of promoting disability inclusion, a lot of high income countries also very... sorry. I had some echo. A lot of high-income countries are also very much would benefit from engaging in this process. So what we do is we can't just destroy all of the health system that exists and then rebuild it from scratch. But it's very important to start to raise awareness among the ministries of health of those issues. And I think that's the first phase almost of the Guide for Action, is to really put disability inclusion on the map, because a lot of people working in ministries of health are not very aware of those challenges, of those barriers, and how the system itself can be discriminatory for a large group of people. It's not that people have bad intentions or malicious or wanting to exclude people. Usually it's the lack of awareness and recognition that there are those issues. So just advocating, telling those stories can actually play a big role into changing mindsets and making people realize, people who have those decision-making power, realize that, yeah, there's things we can do. And actually, a lot of those things don't cost that much money. So that's another big argument that we try to put on the map, is that changing attitudes. It's something that we all need to do, but it doesn't have to cost a lot of money to create something to change attitudes. It's about raising awareness and making sure that disability inclusion is always in discussions when we do new actions within the health system. So yeah, I hope that kind of gives some pointers to answer your question. Then on the question around physical activity, that's a very good question, and I'm actually keen to hear your views, Matthew, and your ideas on how to promote that, how to promote physical activity for persons with cerebral palsy or mobility difficulties. I think, again, it's definitely going to vary from person to person. Some people have different mobility and levels of functioning, but it's about, I guess my point was trying to raise awareness that there's always adaptations that we can be thinking about. And we're at this stage now where those adaptations are often not even thought about, or there's not even that first recognition phase. So it's about really thinking that a one-size-fits-all approach is not going to work, but we need to be thinking of things that we can do so that it becomes more accessible to more people with different needs. And the question from Michael, I don't know if it's in the chat now, but perhaps I'll leave the floor to the other panelists to comment and get back if there's any other questions.
I think Michael's question really went back to something he had put in the chat before, which is about this whole question of how we can put together these grassroots level frontline service provider organizations who are really working in low and middle income countries with the big organizations, WHO, with other organizations that can actually help to change the situation. So I think we've already addressed that to some extent. Time is running out, and I would like to give a last word to each of the panelists. From today's webinar, what would be your key takeaway, your key message for how we get to improve health equity for people with cerebral palsy and other disabilities? And I'll maybe give the floor first to Abir.
Yes, first, thank you for this webinar and for giving me the opportunity to share our experience. I think that in my case, in our case in Lebanon, so far we cannot rely on the government to have appropriate service for CP children. I think the private sector is covering the need, and NGOs, especially NGOs, because we don't have, the population cannot, most of our population cannot cover the fees of services. I think we should, I don't know, work on pilot projects, like small projects, pilot projects, so we can enhance as much as we can and like the services to our children, and to cover as much as we can population who are not based in an area where we practice. So we have this concern at Cerebral. We really have this concern, and we already worked on a pilot project related to inclusion in a governmental school. And you are pushing the government to take this pilot and to improve it, because you are not the government. We don't have the means, we don't have fundings. But the only way so far is to create these pilot projects. We will start, because, for example, we don't have a register for CP. So we will initiate this step, and we will start creating this in a small area. And, we will do our statistics, at least to have the prevalence of this population in Lebanon, so we can fight for them. So this is the only way. Like, we need to think about creating these small, efficient pilot projects, awaiting to have a national strategy that might help CP children and adults.
Thank you, Abir. Micah, last thoughts.
Yeah, well said, Abir. And I also comments Melanie, Raphael, all of you made. I'm just echoing them. I think fundamentally, what we've seen across the comments and both it's been spoken and been typed up is that, we have to change attitudes. And if you look at the number of the people who have disabilities, we all know someone who has disabilities. There are going to be people within our families. This is true for everyone across the world. So it really is education, it's advocacy, it's finding strength in numbers and those common themes of what we need to do to really help improve care. So this is one terrific effort of doing that. So thank you very much, John.
Thanks, Micah. And Raphael.
I would have to say, make information and knowledge accessible. Talk about it. When I say accessible, it doesn't mean necessarily studying it or downloading PDFs or anything like that. I'm talking about talking about it, discussing it during our dinner table or in schools or in NGOs. It doesn't matter, with a family member. I think that's very important, because knowledge and information cannot be something exclusive for healthcare givers or healthcare professionals. It is important that it is, but it also needs to be accessible for families and people with CP, because that is actually the backbone of looking at us as a full person, or even looking at myself as a full person. So that is very, very important. And the attitude of being there, like I said before, it's also something that it's groundbreaking. It's something very simple, but it is groundbreaking. We need to show society that we exist and that we matter. It's kind of weird to say that, but we do. And we cannot look at ourselves as victims. That is also something very important. We need to be empowered, and everybody can empower everybody. So, yeah, I think that would be my final words. Empower everybody. That's a very good start.
And I'd like just to echo that in a way and to say that, we've been working with WHO on developing a global platform for disability health equity. And one of the points is it really needs to be not just a top-down, but a bottom-up approach. So WHO developing this great guide for action provides the framework for things to happen. But there also needs to be what's described as demand creation at the ground. We need to be advocating at the ground for this to happen, for this to be implemented. And so that really is also it's a two-way process, and it's something that you can all contribute to as well. For the last few concluding remarks, I think, Nonye, are you going to give us some final thoughts?
Yes. You must all agree with me that this has been very exciting, quite interesting, and informative. I personally have learned a lot. I must commend all the discussants. Yeah, I will close by repeating what Raphael said, maybe paraphrasing, that you cannot be shy about talking about disability, cannot be shy about talking of cerebral palsy, and who better to talk about us than those of us who live the experiences and the professionals who work with us and our children. It is only us who can do the work. It's encouraging that the WHO is stepping up to talk about cerebral palsy, and I'm hoping that this is a continuation. There'll be a continuation of this. Thank you very much, all of you.
Thank you. Thank you to Melanie and to all our panelists. Thank you more widely, I think, to the World Health Organization for being open to this engagement with ICPS and with the member organizations. And just before you leave, I want to share with you a save the date for the next webinar that we are organizing, which will be in March. And I want to share with you in particular because it picks up on some of the observations that were made. This time we're looking at assistive technology, and in particular how to ensure that we can provide, I think to use Abia's word, appropriate assistive technology for individuals with cerebral palsy in low and middle income settings, and looking in particular at localized production possibilities. So this is a cooperation with the Global Disability Innovation Hub at University College London, which is a WHO collaborating center for assistive technology. It was originally planned as a side event for the GATE Summit on assistive technology, which was planned for May, but that's been postponed. But we're still going ahead with this. So this is really going to be looking at the needs of people with cerebral palsy in low and middle income settings, and how to put together and bring together the engineers, the designers, and the manufacturers who can actually help to make a difference in ensuring that people with cerebral palsy get the equipment that they need. Members will be receiving more information shortly, and you'll also find more information on the website. So thank you all, and I wish you a good rest of the day.
Thank you. Bye-bye.